Hello everyone, I am Dr. Anindita Maiti, Assistant Professor Community Medicine in IPGMER, and today as a part of UG Exam Ready series, I am going to discuss paper 1 and paper 2 of MBBS phase 3 part 1 internal assessment from IPGMER in the subject of community medicine. Now coming to the paper 1 first, section A had 2 questions. The question number 1 was mention any 2 differences between epidemiology and clinical medicine, describe the primary characteristics of a point source epidemic, discuss the periodic fluctuation of epidemics with examples, how the geographic distribution may affect descriptive epidemiology, and mention any one function of descriptive epidemiology carrying total 15 marks. Now coming to the first part about mentioning any 2 differences between epidemiology and clinical medicine, which is carrying 2 marks, you can mention any 2 differences. For example, most important is epidemiology is the study that studies the disease in population or community, and clinical medicine studies disease in individual patients. Secondly, the focus of epidemiology is on distribution and determinants of disease, and clinical medicine focuses on the diagnosis and treatment of disease in individuals. In the second part, we have the question that describe the primary characteristics of a point source epidemic carrying 3 marks. Now here we have to first tell what is a point source epidemic. Now a point source epidemic occurs when a group of susceptible individuals is exposed to a common source of infection at one particular point in time, right. And the characteristics are definitely number 1, the cases occur within one incubation period. Secondly, the epidemic curve shows a sharp rise and a gradual fall, and you can also give a schematic diagram of this epidemic curve here. And thirdly, there is usually no secondary propagation of infection from person to person. For example, you can mention about a food poisoning following the consumption of contaminated food at a common feast, and that is the second part of this question. Now coming to the third part, which the question was discuss the periodic fluctuation of epidemics with example carrying 4 marks. Now here first you tell about what is periodic fluctuation. It is the occurrence of disease in a population with regular or cyclical variation over time. Now it may occur due to many variations, firstly seasonal variation, next cyclical variation, secular variation and short term variation, and you can all give one line of each with an example. For example, I can just tell one, like in seasonal variation, influenza or respiratory tract infections, they increase during winter months, cholera and diarrhea diseases increase during warmer months, especially in rains, right. Now coming to the next part, which carries 5 marks, the question was how may geographic distribution affect the descriptive epidemiology. Now what is geographic distribution? It describes the variation of disease occurrence according to place. It is an important component of descriptive epidemiology because we describe this epidemiology in terms of time, place and person distribution. Now geographic distribution is talking about the place. Now this distribution may be studied in different levels. Number 1, international variations, for example malaria is common in tropical regions but very rare in temperate climate. Now secondly, national or regional variation, diseases may vary between states in a same nation, for example dengue or malaria again. Urban and rural differences, some diseases may be more common in urban areas and some are common in rural areas. Local variation, that is maybe in a particular village or in a particular community there may be variations. And what is the importance of this geographic distribution? Because it helps identify the risk factor, environmental influence, sources of infection and high risk areas. So that is how we can write this question. And the last part of this question was mention any one function of descriptive epidemiology carrying only 1 mark, and there you have very important points. You all know that descriptive epidemiology is basically used mainly to describe the distribution and magnitude of the disease according to time, place and person, or you may also mention that it helps in generating the hypothesis regarding the possible cause or risk factor of the disease. Now coming to question number 2, discuss the concept of impairment, disability and handicap in relation to a case of accident resulting in below knee amputation, which carried 6 marks, and explain the impact of disability on quality of life and well-being, carrying 3 marks. Now, concept of impairment, disability and handicap in this case, which is carrying 6 marks, we must mention that the classical WHO ICIDH framework, that is International Classification of Impairment, Disability and Handicap, was published by WHO in 1980 as a conceptual model to classify the linear consequences of disease and chronic health conditions, right. Now, this WHO ICIDH framework explains the progression as disease or disorder, followed by impairment, then disability and handicap. Now, in this case, which the question is talking about the below knee amputation. If you can write the terms in a tabulated manner with the meaning in the next column and application to this case, then it will be very good to see. Now, if the term impairment, what is the meaning? Any loss or abnormality of psychological, physiological or anatomical structure or function. And the application is loss of the lower limb here below the knee and associated loss of normal limb function. Disability meaning any restriction or lack of ability to perform an activity in the manner considered normal for a person. Now, what is the application here? Difficulty or inability to walk, run, climb stairs, stand for long periods, etc. And thirdly, handicap. It is a disadvantage for an individual resulting from impairment or disability that limits or prevents fulfillment of a normal role. Now, what is the application to this case? Difficulty in returning to work, earning a livelihood, loss of daily wages, participating in the social activities, sports or any family responsibility. Thus, in this case amputation is the impairment, inability to walk normally is the disability and inability to resume occupational or social role is the handicap. In the modern ICF framework, the emphasis is on the body function and structure, activity, participation, environmental factors and personal factors rather than the older term handicap. So, when we are writing the answer of these questions, please mention about the ICF framework also after you have explained those terms. The second part was impact of disability on quality of life and well-being in 3 marks. Now, disability may adversely affect the physical well-being, psychological well-being and social and economic well-being. In physical well-being, what would be there? Reduced mobility, dependence on others. So, there will be loss of independence to do daily work, pain and definitely complications. Now, the psychological well-being, anxiety, depression, low self-esteem, loss of confidence and altered body image. Social and economic well-being would include social isolation, difficulty in education, difficulty in employment, loss of income and increased financial burden, only not to the individual, but also to the family as well. Overall, disability can reduce independence, dignity, social participation and finally the quality of life. Now, what is rehabilitation? Rehabilitation is the combined and coordinated use of medical, social, educational and vocational measures to train or retrain a person to the highest possible level of functional ability and independence. In simple terms, this rehabilitation aims to help a person with disability achieve maximum physical, psychological, social and vocational independence. Now, application of different methods of rehabilitation in this particular case for a person with below knee amputation, rehabilitation should be multidisciplinary. What are those disciplines? Medical rehabilitation, vocational rehabilitation, social and psychological. In medical rehabilitation, you can write about proper wound and stump care, pain management and prevention of contractures, physiotherapy and strengthening exercises and prosthetic limb fitting and gait training. In the vocational rehabilitation, you can write about these following points, that is assessment of the work capacity of that individual, skill training or retraining, modification of workplace and assistance in suitable employment. Social rehabilitation will include family counseling and social support, facilitate the social integration and participation in the social events, prevent stigma and discrimination. Lastly, psychological rehabilitation, we will be talking about counseling and emotional support, management of depression, anxiety and altered body image, and improve the self-esteem and confidence. So, basically the ultimate goal is to enable the person to gain maximum independence and participation in family, social and occupational life. Now, starting with section B, question number 3 was, following heavy rainfall, severe flooding occurred in several villages of Uttar Dinajpur district. Now, many families were displaced from their homes and shifted to temporary relief camps. The drinking water sources were contaminated and sanitation facilities in the camps were inadequate. Now, the questions were, what is a disaster? List the health hazards that may occur among people living in the flood relief camps. As the medical officer of the relief camp, what measures would you take to prevent and control these health hazards? Now, coming to the definition of disaster, that is the first question, what is a disaster? You can refer to any standard textbook. For example, the definition of disaster, it is a serious disruption of the functioning of a community or society causing widespread human, material, economic or environmental losses that exceed the ability of the affected community to cope using its own resources. So, basically what happens is disaster, you need help from outside that area. So, the clues are basically you must remember these words: serious disruption, widespread loss and exceeds the coping capability, right. Now, if we list the health hazards among people living in a flood relief camp, as mentioned here, we can talk about the water and foodborne diseases, including acute diarrheal diseases, cholera, typhoid, hepatitis A and E, food poisoning. Secondly, vector-borne diseases like malaria, dengue, Japanese encephalitis wherever it is endemic, and other mosquito-borne or vector-borne diseases. Thirdly, respiratory and communicable diseases like acute respiratory infection, ARI, influenza-like illnesses. Tuberculosis transmission due to overcrowding is also very important. And the fourth one was other health problems like skin diseases, fungal infections, injuries and accidents definitely are very common in flood, snake and other animal bites, malnutrition, especially undernutrition in children, mental health problems and psychological stress, exacerbation of chronic diseases due to interruption of treatment, because people cannot seek the healthcare facility at that point of time in a disaster. Now, for this question, at least 6 to 8 hazards under broad headings you should be writing, and just remember, any question comes about a disaster which is including flood, you should these things should come to your mind about flood causes contaminated water. So, poor sanitation, overcrowding, and then write accordingly, right. Now, as a medical officer, what measures would you take? And as a medical officer means you are the team leader of the health team. So, you need to plan about safe water supply. We have to ensure an adequate quantity of safe drinking water, test the water quality if possible identify the contaminated sources, chlorinate or disinfect the drinking water and maintain appropriate residual chlorine there, provide safe water storage containers with lids, promote boiling here. Generally, we do not promote boiling because it is costly, it costs a lot to those families, but where we cannot give the supply of safe drinking water for maybe 1 or 2 days or 3 days, we can promote safe drinking water by boiling them. Prevent the contamination during collection, transportation and storage. Now, coming to the second point, that is sanitation and hygiene. Now, we have to see that adequate temporary toilet or latrines are provided if possible, and it should be separated for females. We need to ensure safe disposal of human excreta and solid waste, maintain proper drainage and prevent stagnant water accumulation, provide hand washing facility with soap and water, and definitely promotion of personal hygiene and food hygiene. The third point talks about the disease surveillance and early treatment. What is surveillance? It is a continuous scrutiny of the factors that will cause the disease, right. What are the diseases that would be prevalent here? Diarrhea, cholera, fever, ARI and any other vector-borne or epidemic-prone diseases. So, we need to maintain daily reporting of suspected cases, and that would be done only by active surveillance. We need to set up a medical post or health facility for early diagnosis and treatment, that comes under primary prevention. Ensure the availability of essential medicines, ORS, etc. and emergency supplies, and we should be able to immediately investigate and control any suspected outbreak in that area. The fourth point, we will be talking about vector and rodent control. We need to see that there is removal of stagnant water and improve the drainage, use of appropriate larval control and adult vector control measures, promotion of use of mosquito nets and repellents, the personal protection, conduct surveillance for malaria and dengue as locally appropriate, and also control the rodents and prevent food contamination. And finally, the camp organization and special care. So, to avoid overcrowding and ensure the adequate ventilation and spacing, separate the suspected infectious cases whenever necessary, ensure adequate food supply and safe preparation of food, provide special care to the vulnerable population, though they are children, pregnant and lactating mothers, elderly people and person with disability. We need to ensure continuity of the treatment for people with chronic diseases. We need to provide psychological first aid and mental health support, and ensure the immunization and other preventive measures according to the local situation and the guidelines. So, if you need to remember the clues for here, please remember 5 S's, that is safe water, sanitation and hygiene, surveillance and treatment, special care and camp management and vector control. Okay. So, now coming to the question number 4, a middle-aged male from Bihar has presented with fever, anemia and splenomegaly. Now, what is your diagnosis? What are the different methods of laboratory diagnosis? How will you treat this case, and elaborate briefly the control measures of the disease. Now, coming to the first question, the diagnosis carrying 1 mark, definitely a person, middle-aged person from Bihar with fever, anemia, splenomegaly, that is the classical triad for visceral leishmaniasis or Kala-Jar. So, it is VL or visceral leishmaniasis. Okay. Now, other possible findings could be weight loss, hepatomegaly, leukopenia and hyperpigmentation. So, when we are talking about that typical triad, we should also remember that these are also the findings of Kala-Jar which may come later. Now, what are the different methods of laboratory diagnosis here? Laboratory diagnosis can be classified in broad headings like parasitological diagnosis, serological diagnosis and molecular method. 3 points and 3 marks. So, under parasitological diagnosis, we need to demonstrate the LD bodies or Leishman-Donovan bodies, right. What would be the specimen? Splenic aspirate, highly sensitive, but there is risk of bleeding and very difficult to do. Bone marrow aspirate, little safer and commonly used, and lymph node aspirate, wherever lymphadenopathy is present, we should go for lymph node aspirate for the demonstration of LD bodies in microscopy. So, these LD bodies would be seen inside the macrophages, showing a nucleus and kinetoplast. Secondly, serological diagnosis, and here the most important thing is RK39 RDT, RK39 immunochromatographic rapid diagnostic test, direct agglutination test or DAT, and ELISA or other antibody based test. Now, most important, as I have already mentioned, is RK39, because it is widely used for diagnosis in endemic areas of Kala-Jar, but antibody test may remain positive after previous infection also, and so it is not very ideal for assessing the cure of this disease, right. Thirdly, and the last one was molecular method. What is that method? That is polymerase chain reaction or PCR for detection of Leishmania DNA. So, for 3 marks, 3 points and maybe 1 or 2 lines of each of the diagnosis. Now, how will you treat the case which is carrying 3 marks? Now, when you write this answer, treatment depends on geographical area, drug resistance pattern and national guideline. In India, we use liposomal amphotericin B. So, please mention about the treatment by LAMB and the doses also. It is preferred treatment for visceral leishmaniasis in our country. Now, the other drugs or regimens that may be used are miltefosine, amphotericin B deoxycholate and also paromomycin. Now, it should be according to the national guideline, that is National Program for Vector Borne Disease Control Program or the protocol of National Center for Vector Borne Disease Control Protocol. Those are to be followed and written. Now, what would be the supportive treatment for this case? We have to treat anemia and nutritional deficiencies. We need to correct the dehydration and electrolyte disturbances. We have to treat the associated infections if any, and we need to monitor clinical response and also if any adverse effects are happening. Okay. So, specifically anti-leishmanial therapy, supportive treatment and follow up. These are the three headings you should be writing your answers in. Now, control measures of visceral leishmaniasis. Control is based on early diagnosis, complete treatment and vector control, right. So, in early diagnosis and control treatment, you need to talk about active and passive case detection, early diagnosis of suspected cases. Once you have diagnosed, prompt and complete treatment, follow up of the treated cases and detection and management of post Kala-Azar dermal leishmaniasis. Very important, PKDL, which may act as a reservoir. So, we need to detect and manage PKDL cases also. And what will you do? You will go for vector control also, and the vector here for Kala-Azar is female sandfly, that is Phlebotomus argentipes. And what would be the measures of vector control? Indoor residual spraying with recommended insecticides, use of insecticide treated bed nets, personal protections, environmental measures to reduce the sandfly breeding or resting sites and improvement of housing and sanitation. Next would be surveillance and definitely health education. Disease surveillance and outbreak detection is very important point here. Now, community awareness regarding the symptoms and early health seeking behavior is also needed. We need to encourage the early reporting of prolonged fever and splenomegaly cases. Intersectoral coordination and community participation, as we all know, is the basis of the control and prevention of diseases. Okay. So, if for your revision, the clue you may remember Kala-Azar as it is spelled K-A-L-A-A-Z-A-R. K for Kala-Azar, that is visceral leishmaniasis. A for anemia, very common comorbid condition. L for Leishmania donovani, the causative agent. A for a splenomegaly. This A we are using as because splenomegaly comes as from S, but a splenomegaly because spleen is only one, and we have to think about massive splenomegaly in Kala-Azar cases. Next is the treatment of choice, that is amphotericin B. Z is for zero tolerance for untreated cases. You need to do early diagnosis and you need to provide complete treatment. Next is urgent vector control. The urgent comes with U, but just for remembering purpose you can remember urgent vector control, and R for reservoir control including PKDL. So, the framework for exam, if you need to remember, Kala-Azar is the diagnosis, next came the laboratory diagnosis. In that laboratory diagnosis, you would be talking about the LD bodies, RK39 and PCR, followed by treatment by liposomal amphotericin B as per the national protocol, and finally the control. In control, you need to talk about early detection and treatment plus PKDL management and also IRS or vector control and then surveillance. So, that is how we write the question number 4 here. Now, the next question, that is question number 5. A 300 bed hospital has recently started functioning and is implementing the biomedical waste management rules for safe handling and disposal of healthcare waste. Describe the segregation of biomedical waste using the color coded system followed in hospitals. Compare the autoclaving and incineration as methods of biomedical waste treatment. Explain the steps involved in the safe management and disposal of waste sharps. What are the waste sharps? Needles, blades and scalpels from the point of generation to the final disposal. Now, if we need to answer this question, first we should be going for the segregation of biomedical waste by color coding. This also please write what is the rule that we are following now as per the biomedical waste management rules 2016. The waste is segregated at the point of generation into how many categories? 4 categories, and those are all color coded: yellow, red, white and blue. You all know that it is given in all the standard textbook, and please write it in a tabulated manner. Okay. First column will be containing the color coding color codes. Next column would be type of waste, next third one will be examples, and finally the fourth column would be talking about the treatment or disposal of that type of waste. For example, I can just tell you one, the colors you all know is yellow, red, white and blue, and in yellow type of waste will be human or anatomical waste, soiled waste, discarded medicine, chemical waste and microbiology or clinical laboratory waste. For example, human tissue, organs, placenta, blood soaked cotton, etc., and the disposal would be incineration or plasma pyrolysis, deep burial where permitted, and appropriate treatment as per category. Okay. So, accordingly you can write about the red, white and blue also. For remembering these clues, you can remember yellow, red, blue and white. YRWB. Why is yellow? You can't recycle it, right? That is a clue. What would be those things? Anatomical, soiled and medicines. R for red, you recycle, red recycle, okay. Contaminated recyclable plastics will be there. W white, it wounds, wounds mean there may be sharps, right. When you talk about wounds, your brain will work for sharp waste like needles, blades and scalpel. And finally blue, that is bottle, and as we talk about bottle, we think about glass, and glassware and implants are included there. So, those are the clues for you to remember. Segregation must be done at the point of generation, and biomedical waste should never be mixed with general waste, very important. Now, if we go to the next portion of this next part of this question, they asked about comparison of autoclaving and incineration. So, here also it would be very good if you write it in a tabulated manner. So, in the left column you write about the features, the second column would be autoclaving and the third one would be incineration. And the features would be principle, process, suitable for, advantage and limitation. Principle of autoclaving is steam under pressure, incineration high temperature combustion. Process in autoclaving is the moist heat sterilization, and incineration is burning of waste. Now, autoclaving is suitable for infectious waste, plastics and sharps. Incineration is more suitable for anatomical waste, soiled waste and certain pharmaceutical waste. What is the advantage of autoclaving? There is no toxic combustion gases, recyclable material may be recovered after treatment by autoclaving, right. But in incineration, the advantage is significant reduction in waste volume, and it destroys organic matter also. But what are the limitations? Autoclaving does not destroy all chemicals or pharmaceutical, and waste remains. Incineration may produce air pollutants and toxic emissions if poorly operated, as requires safe disposal also. So, those are the points to be written in comparison of autoclaving and incineration. Now, coming to the safe management and disposal of waste sharps, which is carrying 4 marks. Now, these sharps include needles, syringes with fixed needles, scalpel, blade and lancets. The management should follow the sequence: first at the point of generation, second safe handling, third collection and transportation, fourth treatment and final disposal, and fifth occupational safety. Now, what would you write at the point of generation? That is the first point. Segregate the sharps immediately after use, do not mix them with other biomedical waste, and discard directly into a puncture proof, leak proof and tamper proof white translucent container. Okay. Now, coming to the second point, that is the safe handling. We should not recap, bend or break or even manipulate in any way the used needles by hand. Next, do not pass used sharps directly from one person to another person. Use appropriate PPE, that is personal protective equipment, while handling the waste, and containers should not be overfilled and should be sealed whenever. Now, coming to the next part of the question, they ask safe management and disposal of waste sharps carrying 4 marks. Now, what are the waste sharps? Those include needles, syringes with fixed needles, scalpel, blades and lancets. The management should follow the sequence. Number 1 at the point of generation, number 2 safe handling, number 3 collection and transportation, number 4 treatment and final disposal, and number 5 occupational safety. Now, coming to the first point, at the point of generation, segregate the sharps immediately after use. They should not be mixed with any other biomedical waste, and we should discard directly into a puncture proof, leak proof and tamper proof white translucent container. Now, coming to the point safe handling, we should not recap, bend, break or manipulate used needles by hand, never, and we should never pass used sharps directly from one person to another. We should use appropriate PPE while handling the waste. Container should not be overfilled and it should be sealed when approximately 3/4 full. The next point was collection and transportation. Now, close and label the sharps container properly, transport in a dedicated, closed and leak proof trolley or container, avoid manual handling and follow the prescribed biomedical waste collection and barcoding system wherever it is applicable. The fourth point was treatment and final disposal of those. The sharps are treated by autoclaving or sometimes dry heat sterilization as per the standards. After sterilization, they are shredded or mutilated to prevent reuse, and treated sharps are sent for final disposal or recycling through an authorized facility as per applicable biomedical waste rules. And here we should remember, this facility should be present around 75 km in radius from your clinic or from the facility you are working, otherwise you can go for deep burial. Okay. Now, coming to the last point, that is occupational safety. In case of needle stick injury, we should immediately wash the affected area with soap and running water, report the incident immediately, assess the exposure risk, initiate appropriate post exposure prophylaxis PEP whenever indicated. You should always start the PEP and then test the person or the doctor or the healthcare professional. There is no harm starting the post exposure prophylaxis before even the report comes. If the report comes negative, it is okay, but if it comes positive, then it will give you some advantage, right? And we should all follow institutional occupational health protocol. Okay. So, now coming to the section C, which is comprising of short notes. First short note was doctor patient relationship. So, when you write a short note, you define if the topic is given a direct topic like doctor patient relationship, you should first mention about the definition of that topic. The doctor patient relationship is the professional relationship between a doctor and a patient based on trust, respect, communication, confidentiality and mutual cooperation with the primary aim of promoting the patient's health and well-being. Now, what are the principles? You should remember the clues like trust, respect, empathy, communication, confidentiality and ethical conduct. Now, what are the types of doctor-patient relationship? According to Saz and Hollander, there are few types. First one is activity, passivity. Second, guidance, cooperation. Third, mutual participation, very important. Okay. Now, activity, passivity, here doctor is active and patient is passive, used in emergencies, unconscious patients and severe illness definitely. Now, guidance, cooperation, doctor explains, advises, patient cooperates, it is common in acute illness. And in mutual participation, the third one, doctor and patient actively participate in the decision making. It is common in chronic diseases such as diabetes and hypertension. So, what is the importance of having a good doctor-patient relationship? First one, establishes trust and rapport, improves history taking and diagnosis. If improved diagnosis is there, then there will be easy to treatment, and also it will promote the treatment adherence and compliance of the patient. It will encourage the patient participation in decision making. It will help in counseling and behavior change. It will reduce the anxiety and improve the patient satisfaction, and definitely good doctor-patient relationship is very much essential for ethical and patient centered care. Now, the qualities of a good doctor-patient relationship, the qualities we all know: empathy, compassion, active listening, clear and understandable communication, respect for the autonomy of the patient, maintain confidentiality. Your attitude should be very much non-judgmental, do not ever judge a patient. Informed consent is a very important component of this, and definitely the most important quality is maintain professionalism. So, basically when you are writing this question, remember you need to write the definition, then the types, then importance, what is the importance of this doctor patient relationship, and finally the qualities of good doctor patient relationship. Now, coming to the next short note, that is mass drug administration for soil transmitted helminthes. Here also we start with the definition. Definition of MDA or mass drug administration, it is the administration of anti-helminthic drugs to an entire eligible population or defined target group irrespective of individual infection status to reduce the burden of soil transmitted helminthic infection. And here we need to remember three things. First is albendazole, second is target population, deworming and wash, right. So, major soil transmitted helminthes are Ascaris lumbicoides, whipworm, that is Trichuris trichura, and hookworm. What is the purpose? We need to reduce the worm burden, reduce the prevalence and intensity of infection, and prevent complications such as anemia, malnutrition, growth retardation, and poor school performance overall. So, what is the drug used? We generally use albendazole in mass drug administration to the children and adolescents during under the National Deworming Day or NDD program. Okay. Usually the frequency is biannual. So, we do biannual deworming in areas with high transmission according to program recommendation. Okay. So, what are the additional measures that are to be taken? It should be combined with use of sanitary latrine, safe disposal of feces, hand washing with soap, wearing the footwear, safe water supply, washing your veggies and fruits, and health education. So, please remember 3D, drug is albendazole, delivery is mass drug administration, biannual, and disease control combined with sanitation and hygiene. Okay. And you need to also mention or write few lines about wash, that is water, sanitation and hygiene to prevent reinfection. Now, coming to the section D, where you have few explain why questions. The first one was AEFI includes events beyond side effects of vaccine. Now, what is AEFI? Adverse events following immunization, not effects, okay? It is events. It is defined as any untoward medical occurrence following immunization which does not necessarily have a causal relationship with the use of the vaccine. Therefore, AEFI is a broader term than just a vaccine side effect, right. It may be due to 5 things. Number 1, vaccine product related reaction. Number 2, vaccine quality defect related reaction. Number 3, immunization error related reaction. Number 4, immunization anxiety related, or 5th, that is coincidental event which is unrelated to the vaccine. Now, because a medical event occurring after vaccination may be temporarily associated, but not always caused by the vaccine itself, it may be due to an underlying illness, it may be due to immunization error, anxiety, fear, or defective vaccine or vaccination process. For example, please give an example when you are writing this question. A child develops fever after vaccination. Now, it can be a genuine vaccine reaction, right, or it can be due to an intercurrent infection occurring coincidentally, right. Now, so therefore, AEFI never is equal to vaccine adverse reaction, no. So, after vaccination does not always mean because of vaccination, right. I think you can write this question better than me, right. Now, the question number B was diabetes mellitus requires long term self care in addition to medical treatment, explain why. Now, diabetes mellitus is a chronic metabolic disorder requiring lifelong treatment or management rather. Medication alone cannot maintain the optimal glycemic control. Self care is very important. Now, if you know the prevention of the complications of diabetes, which will include dietary modification, exercise or physical activity, adherence to medication and monitoring, tobacco cessation, healthy lifestyle, and finally the home based monitoring and foot care. Diabetic foot care is very important. Now, what is the importance of self care? Self care helps us to maintain the blood glucose within the target range, prevent the acute complications of diabetes, delay microvascular complications like retinopathy, nephropathy and neuropathy, we all know about it, reduce the macrovascular complications like coronary artery disease, stroke and peripheral vascular disease, prevent the diabetic foot ulcers, improve the quality of life and finally reduce the healthcare cost, otherwise it would be catastrophic, right. So, to conclude, diabetes is a chronic disease in which the patient is the key participant in day to day management. Hence, medical treatment must be supplemented by continuous self care, education and lifestyle modification, because in diabetes doctor treats, patient manages every day of his or her life. The next explain why question was, slow sand filters require several days for proper functioning after installation, explain why. Now, what is a slow sand filter and what does it do? It does not function effectively immediately after installation, because it requires the development of the biological layer or that is called the smudge deck layer on the surface of the sand bed. And please mention the process of this biological layer formation. You can write 2-3 lines that during the initial period the microorganism colonize in the upper surface of the sand, and then the biological active layer is developed. This layer helps to remove the bacteria, protozoa, organic matter and suspended impurities, thus disinfecting the water in the filter. So, what is the significance is it is most important component of the biological purification process, this biological layer. Therefore, a newly installed slow sand filter requires a ripening period. So, when you are writing about this question, remember the words slow sand filter, biological layer or smudge deck layer, biological action and ripening period. If you remember these 4 words, I think you can write the answer very nicely. The next question was, there is no scope of giving advice in counseling, explain why. Now, this statement is very correct, isn't it? Why? Because counseling is different from advice giving. Counseling is a two-way person centered process in which the counselor establishes rapport with the patient or the person, listens actively from the patient, helps the person explore his or her own problems, identifies their own concerns and possible solutions and gives support the informed decision making of that person. In contrast, advice giving is very much directive. The advisor tells the person what to do and the patient needs to follow. Now, why this advice should be avoided in counseling? The counselor may not fully understand the person's situation, the person may become dependent on the counselor, advice may not be acceptable by the patient also, or it may not be feasible by him. It reduces autonomy of the patient and self determination, and it may create resistance to behavior change. So, that is why we do not give advice when you are counseling. For example, if we say you must stop smoking immediately, it is advice, but in counseling what would we say? What difficulties do you think you may face if you try to stop smoking, and what strategies might help you to overcome them? What do you think? So, I am leaving it to the person next to me, so that informed decision making and behavior change is also expected there. So, counseling facilitates the person's own decision making, and counseling talk about facilitating the process, but not to dictate him. Okay. The last explain why question was, for small sample median is a better measure of central tendency than mean. Why? The median is the middle value, we all know, when observations are arranged in a ascending or descending manner. Now, for a small sample, especially when the data are skewed or it contain extreme value, then the median may better represent the central location of the observation, we all agree, right. What is the advantage? Because median is not affected by extreme values or outliers, it is suitable for skewed distribution, it can be used for ordinal data, easy to calculate and interpret, and it gives us a more representative value when a few observations are unusually high or unusually low. For example, if we see a small data set like 2, 3, 4, 5 and 100. Now, what would be the mean? The mean would be 22.8, but the median is 4 here, if you arrange it in ascending or descending manner. Now, here the value 100 is the extreme value and greatly increases the mean, but the median of 4 is better representing the typical observation. So, in a small sample with skewed distribution or outliers, median is definitely better because extreme value can pull the mean, but it cannot manipulate the median remains stable. Now, the next section was the MCQs, and we are not going to discuss MCQs today, you can solve those MCQ yourself. So, that is paper 1. Thank you very much. So, now we are going to discuss the paper 2 of community medicine in MBBS phase 3 part 1 internal assessment at IPGMER Kolkata. In section A, question number 1, the questions were: define health planning, describe the steps of the health planning cycle in context to reported rising outbreak of dengue in a district. Differentiate between cost benefit analysis and cost effective analysis in relation to health management with suitable examples. Now, coming to the first part, that is the definition of health planning. From any standard textbook you can write the definition, that is health planning is defined as an orderly systematic process of defining community health problems, identifying unmet needs, surveying resources, establishing priority goals that are realistic and feasible, and projecting administrative action to accomplish the targets of the plan. Now, coming to the health planning cycle in context of a dengue outbreak, you all know the main points, you know about the planning cycle. The headings would be analysis of the health situation, establishment of objectives and goals, assessment of resources, fixing priorities, formulation of plan and action, programming and implementation, and finally monitoring and evaluation, and thus the cycle goes on, right. So, please under these headings you need to write giving the context of dengue here. Now, in the analysis of the health situation, collect the epidemiological data regarding positive dengue cases, spatial clustering, vector density of those indicators, total population affected by this disease, and available hospital beds or testing facility in the district. The second one was establishment of objectives and targets. Definitely after you have done the analysis of the situation, you need to set specific goals such as reducing the case fatality rate of dengue to less than 1%, bringing the Bratu index down to less than 20, and ensuring zero delays in platelet transfusion over the next 4 weeks. Now, assessment of resources, in that you should write about evaluation of available medical staff like doctors, nurses, field workers, diagnostics like NS1 antigen kits, IgM ELISA kits, etc. Treatment supplies like we need IV fluids, IV sets, blood components, larvicides, and financial budget under the National Vector-Borne Disease Control Program. Fourth point is fixing priorities. We need to prioritize the high risk blocks or wards with maximum case density and severe cases like dengue hemorrhagic fever, dengue shock syndrome over the low incidence area. We need to prioritize those serious areas, correct. Now, the fifth one is formulation of the plan or action plan. We need to draft targeted interventions including the vector control measures like fogging, source reduction, you write about source reduction, early diagnostic protocols, designated isolation wards in the facilities, and information, education, communication or IEC campaigns. Next point is programming and implementation. Now, deploy the domestic breeding checkers for door to door larval survey, execute spatial anti-larval sprays, set up rapid response teams at PHCs, CHCs, and establish 24/7 fever clinics. And finally, the monitoring and evaluation. Write what is monitoring, write what is evaluation, and then write that we need to continuously track daily fever counts, line listing of the cases, vector indices, and we need to compare post intervention metrics against initial targets to adjust strategies dynamically. Now, the next question was cost benefit analysis versus cost effective analysis. Please write it in a tabulated manner. In the first left column there would be features like definition, outcome unit, application and example. Then you compare in the next two columns about cost benefit analysis and cost effective analysis. For example, just I will talk about the first point, that is the definition. In cost benefit analysis, it is an economic evaluation tool where both cost or input and outcome, that is the benefits, are measured in monetary terms. Cost effective, it is an economic evaluation tool where costs are measured in monetary terms, but outcomes are measured in non-monetary or natural health units. Then you talk about the outcome unit. In cost benefit analysis, it is currency or monetary value, like this much rupees saved or dollars saved, and cost effective analysis, natural health unit like life years saved, disability adjusted, life years, DALYs averted or cases prevented, like that, right. Then you write about application and give example of both. Now, coming to the next question, that is question number 2. Enumerate maternal and child health indicators. What are the common causes of perinatal mortality in India? Describe measures taken by government to ensure child survival. Now, talking about the first part, that is the maternal and child health indicators. Enumerate means you need to mention the names mainly, right. So, maternal mortality ratio, number of maternal deaths per 1 lakh live births, antenatal care coverage, institutional delivery rate, prevalence of anemia in pregnant women, etc. Those are maternal indicators, and you can add few more. Child health indicators, infant mortality rate, what is it? Number of infant deaths or less than 1 year of age per 1000 live births. Now, under 5 mortality rate, perinatal mortality rate, etc., etc. And you can also include fully immunized child coverage in this case also. Now, what are the common causes of perinatal mortality in India? If we talk about the causes, antenatal and intrapartum causes, which includes both fetal and maternal causes, are prematurity, low birth weight, and that is the single largest contributor to early neonatal deaths. Birth asphyxia and hypoxic ischemic encephalopathy, delayed transport, obstructed labor, lack of skilled birth attendant, these factors are responsible for birth asphyxia and hypoxic ischemic encephalopathy. Maternal complications also like preeclampsia, eclampsia, severe maternal anemia, antepartum hemorrhage due to placenta previa or placenta abruptio are the causes. And finally, the postnatal or early neonatal causes includes perinatal infections like neonatal sepsis, pneumonia and umbilical cord infections, congenital anomalies like major structural defects incompatible with early life. Now, the next question was government measures to ensure child survival in India. Okay. So, what are those? Please mention about the management programs like IMNCI, RBSK, SARS and many more, and write about what are the immunization program like UIP, Universal Immunization Program, and now it is the Mission Indradhanush is going on, nutritional scheme like Poshan Abhiyan, right, and health infrastructure like SNCU, NBSU, home based newborn care, etc. and financial and screening like Janani Suraksha Yojana, JSY or JSSK like Janani Shishu Surakha Karyakram. You need to mention all these in a tabulated manner, and then you explain a little bit of each one of it. Okay. So, for example, I will just talk about IMNCI like integrated management of neonatal and childhood illness that focuses on preventive, promotive and curative care of major childhood killers like pneumonia, diarrhea, malaria, measles, malnutrition at the community level as well as in the facility level. Immunization program like Universal Immunization Program and now Mission Indradhanush, they provide free vaccine against vaccine preventable diseases to all the children of our nation, and the Mission Indradhanush now is targeting unvaccinated and partially vaccinated children also in hard to reach pockets of the country. So, likewise you talk about facility based and home based newborn care, you talk about the national initiative for specific childhood illnesses like SARS and Stop Diarrhea campaign, Rashtriya Bal Swasthya Karyakram RBSK, you talk about the 4 Ds till from 0 to 18 years of age children, and then you can talk little bit about the nutritional programs like Poshan Abhijan and mother's absolute affection, etc., etc. I think you will be able to write that question. Now, coming to section B, question number 3, a 45 years old male mining worker presents to the primary health center complaining of gradual worsening of dyspnea and chronic cough. An X-ray of the chest shows eggshell calcification in lung fields. What is the provisional diagnosis of this case? How this case should be managed? What are the measures to be undertaken to prevent this type of disease? Now, coming to the provisional diagnosis, it is definitely silicosis, that is an occupational pneumoconiosis resulting from long term inhalation of silica dust. Now, diagnostic basis, history of working in mines, exposure to free silica or quartz dust, progressive dyspnea, chronic cough, classic eggshell calcification of the hilar or mediastinal lymph node as mentioned on the chest X-ray are the clues for diagnosis. Management of the case, silicosis is irreversible and it is progressive occupational lung disease. So, the management is primarily supportive and palliative. So, what are the headings that you would write to write the question? First one, you should write about the removal from exposure, that is immediate cessation of work in dust prone mining environment to prevent further disease progression. Second would be symptomatic and supportive pharmacotherapy like bronchodilators for airway obstruction, inhaled corticosteroid if reactive airway disease coexist, supplemental oxygen therapy for severe chronic hypoxia, especially if it comes below 90 or 88% SpO2. Right. The next point you will be writing about screening and management of complication, and what is the disease that we should screen in these cases, that is TB, like tuberculosis screening. In silicosis, susceptibility to Mycobacterium tuberculosis is exceptionally high and it is known as silicotuberculosis. So, we need to perform the baseline sputum examination, AFB smear, CB-NAT and sometimes tuberculin test also. Prompt management of secondary bacterial respiratory infection with appropriate broad spectrum antibiotic may be needed. The next point would be pulmonary rehabilitation and immunization, where we need to do pulmonary rehab programs including the breathing exercises, annual influenza and periodic pneumococcal vaccinations to prevent lower respiratory tract infections to all. And finally, compensation and legal notification. It is mandatory that the notification under the Mines Act 1952 or Factories Act 1948 is given. Assistance with disability assessment for financial compensation under social security schemes are also there. So, we need to notify. The preventive measures for silicosis would include engineering controls, administrative and workplace controls, personal protective equipment and medical surveillance. These are all given in any of the standard notebooks. Please write under these headings the preventive measures for silicosis or for say for any occupational lung diseases. Engineering controls, that is primary level, would include dust suppression, local exhaust ventilation and substitution, and please write what are those. Administrative and workplace controls like workplace environmental monitoring, job rotation, hygiene practices, personal protective equipment, use of certified respiratory protective equipment such as N95 or N100 mask or positive pressure air purifying respirators. Medical surveillance, it comes under secondary level of prevention, pre-employment examination, periodic medical examination after employment and then health education. So, under these headings you can write the answer of this question. Now, coming to question number 4, the question was a primary health center in Bajbaj serves a population of 32,000. During a community survey, it was found that the villages are having high birth rate and increasing population growth. Enumerate 4 demographic indicators, define one of them and mention its significance in demographic assessment. Advise suitable family planning methods for an eligible couple with one living child and mention one advantage of each method. Okay. Now, coming to enumeration of 4 demographic indicators. Enumeration means you give the names like crude birth rate, total fertility rate, infant mortality rate, sex ratio or dependency ratio, etc., whatever you know about the demographic indicators. Now, coming to the definition and significance of total fertility rate, it is the TFR is defined as the average number of children that would be born alive to a woman during her lifetime if she were to pass through all her childbearing years, that is 15 to 49 years, conforming to the age specific fertility rate of a given population in the given year, right, and please mention the formula of TFR also. Now, significance in demographic assessment. What is the significance of this in demographic assessment? It reflects the completed family size, it gives an exact measure of current fertility behavior independent of age, sex, structure of the population, unlike crude birth rate, right. It measures the replacement level fertility. A TFR of 2.1 we all know represents the replacement level at which a population exactly replaces itself from one generation to the next generation without migration. And finally, guides the population policy, because it indicates whether a population is expanding, like TFR is more than 2.1, stabilizing, TFR is 2.1, and shrinking, that is TFR is less than 2.1, directly informing local public health and family planning allocation strategies. Number 3 was family planning methods for an eligible couple with one living child. I mean the third part of the question were this, right. For a couple with one living child seeking a delay or space for the second child, spacing methods are indicated. Now, what are the suitable spacing methods? It can be IUCD, that is intrauterine contraceptive device, oral contraceptives like OC pills or POPs, and barrier method. Please write about the examples, like in IUCD you will be writing about the copper T380A and others. Oral contraceptives can be combined OCPs like Maline, Malady, and barrier methods like male condom, female condom, etc. And please write about the advantages of each of them. Okay. So, IUCD's advantage, it will provide long acting, highly effective, reversible protection with zero daily compliance needed, no daily compliance needed, right. OCP, fully user controlled, rapidly reversible, and offers non-contraceptive benefits like regulation of menstrual cycle and reduction in dysmenorrhea also. Injectable contraceptive by like DMPA or Antara program, the advantage is it requires only a single IM injection every 3 months, offering privacy, ease of use, and high compliance without daily action. And barrier methods like male or female condom, etc. Here the advantage will be it will provide dual protection by preventing unintended pregnancy and offering absolute protection against the STDs and HIV. Now, coming to question number 5, a 52-year-old man with diabetes and hypertension visits a health and wellness center for regular follow-up. During examination, complications are suspected and referral is advised. Describe the major components of the Ayushman Bharat program. What services for non-communicable diseases are available at health and wellness centers? Suggest 6 indicators that can be used to assess the performance of a health and wellness center. Now, when you are talking about the first part of this question, that is major components of Ayushman Bharat, launched under the National Health Policy to achieve universal health coverage, that is UHC, it has 2 main pillars. Pillar 1, Ayushman Arogya Mandirs, and pillar 2, PMJ, that is the health insurance. Okay. So, please write about the Ayushman Arogya Mandirs, few points, and also PMJ or the health insurance, few points. So, more than 1,50,000 upgraded facilities are there as HWCs, now Ayushman Arogya Mandir. The scope is upgraded sub-centers and primary health centers. Comprehensive primary care is given and preventive, promotive, curative and rehabilitative services are given there. Free essential supplies like free essential drugs and basic diagnostic testing are available. Pillar 2, which is talking about the health insurance, there is coverage for vulnerable population. The target is bottom 40% of the poor and vulnerable families across the country. Financial protection is being given. Entitlement of how much? 5 lakh rupees coverage per family per year for secondary and tertiary inpatient care. Okay. It is cashless and paperless, and empaneled public and private healthcare providers will get the access. So, I think you can write that. The next part of this question was NCD services available at health and wellness centers, that is the Ayushman Arogya Mandirs now. So, universal screening, early detection, management and follow up of major non-communicable diseases are there, like hypertension. For hypertension, measurement of blood pressure for all individuals more than 30 years of age, diabetes mellitus, random and fasting blood sugar testing using glucometer, common cancer screening like oral cancer by visual examination, cervical cancer by VIA, that is visual inspection with acetic acid, breast cancer like clinical breast examination or CBE, then provision of essential NCD drugs, free dispensing of antihypertensives, example amlodipine, telmisartan, oral hypoglycemics like metformin, etc. Continuum of care and referral linkage to community health centers, that is the CHCs or district hospitals for complicated cases, alongside the teleconsultation, the telemedicine support via eSanjeevani. Wellness promotion, daily lifestyle counseling, diet management, tobacco or alcohol cessation guidance and regular yoga or wellness sessions. Now, if we are talking about go to the next part of the question, 6 performance indicators for assessment of the HWCs. It can be OPD attendance count, NCD screening rate, teleconsultation utilization, availability of essential drugs and diagnostics, wellness activity index, that is number of yoga and health or wellness session conducted per month in that particular center, and finally 6th one, patient satisfaction score or community assessment. Okay. Here rating based on the Jan Arogya Samiti, that is JAS, community audits and feedback scores. So, these are the 6 points you need to mention about the 6 performance indicators for assessment of HWC. Now, coming to section C, where they gave short notes on feeding guidelines for 6 months to 2-year-old child or complementary feeding. So, basically why after 6 months? Because they need to know about what you know about complementary feeding. Now, complementary feeding is the process of introducing nutritionally adequate, safe and appropriate feeds to an infant at 6 completed months, while continuing breastfeeding, because breast milk alone is no longer sufficient to meet the growing nutritional requirement of the child. Now, what are the guidelines? First, we need to start complementary feeding at 6 completed months. Begin complementary feeding after 180 days of age, continue breastfeeding till 2 years of age and beyond. Frequency of feeding, when the baby is of 6 to 8 months, 2 to 3 meals per day plus 1 or 2 nutritious snacks along with breastfeeding. 9 to 11 months, 3 to 4 meals per day with 1 or 2 snacks with breastfeeding. 12 to 24 months age, 3 to 4 family meals per day plus 1 to 2 nutritional snacks along with breastfeeding. Now, what should be the quantity? Start with small quantities and gradually increase. By 12 months, the child should be eating a variety of family foods, homemade family foods in appropriate consistency and quantity. What about the quality and variety? We should provide a diverse, energy dense and nutrient rich diet including cereals, millets, pulses, legumes, vegetables including green leafy vegetables, fruits, milk and milk products, and in non-veg we can give egg, fish wherever applicable, later we can add meat, and oil or ghee in appropriate amount. The consistency, we should start with thick, mashed and soft food, then gradually progress to lumpy, chopped and finger foods, and after some time the child should be able to eat the family foods in suitable consistency. Now, coming up about the responsive feeding. What is responsive feeding? Feed slowly and patiently, encourage but do not force the child to eat. Response to hunger and satiety cues, you have to identify those. Talk to and interact with the child during feeding, he should enjoy feed. And principle of active or responsive feeding is feed patiently, encourage the child without force feeding. Please remember that. And finally, hygiene and safety are to be maintained. Hand washing with soap and water before preparing and before feeding the child. Clean utensils should be used. Safe drinking water should be provided. Okay? And do not hurry, otherwise it may cause choking also. Now, what are the foods to be avoided or limit? Honey before 1 year, excessively salty or sugary food, sugary drinks, junk or ultra processed food, tea or coffee, whole nuts and other choking hazards, and also we should avoid using bottle feeding. We should use a clean cup or bowl and spoon instead. Okay. Now, we should also see about dietary diversity and safety. You all know about dietary diversity. Please write about the variety of food that should be included and what are the things to be avoided. Now, coming to the next question, that is role of health communication in increasing vaccine acceptance. Now, health communication is the strategic use of communication strategies to inform, influence and empower individual and community decisions regarding health. In immunization, it serves as the key driver to move population from vaccine hesitancy to vaccine acceptance. Now, what are the core roles and strategies? First role or strategy is building trust and countering the misinformation, right. So, transparently addresses rumors. We should transparently address the rumors, myths and fears, like fears of infertility or severe side effects via trusted channels like doctors, religious leaders and community health worker like ASHA. Risk communication and disease awareness. Under this you can talk about highlighting the severity and susceptibility of vaccine prevented diseases, helping the parents or the caregivers weigh the benefits of vaccination against the non-action. Targeted social and behavior change communication employs the culturally appropriate messages using localized media like street play, nukkad nataks, folk songs, role plays, local radio and the broadcast tailored to hesitant subgroups, and enhancing the social norms by positively framing the vaccination as a responsible social and parenting norm. That is, you can say like protect your child, protect your community campaign. Interpersonal communication, it talks about pre and post vaccination counseling by the healthcare personnel addressing the parents of the children concerns empathically during routine immunization sessions. For example, advising on managing the post vaccine fever. Likewise, you can write this question. Now, coming to the explain why questions in section D, the first one was nothing in earth is more international than disease. Why? Because microbes respect no borders. As we all know, we have passport, but the microorganisms they do not have. They can just travel from one continent to another continent it is a matter of 3 to 4 hours flight, right. So, the pathogenic organisms, viruses and bacteria, they propagate via human vectors, trade goods, animals and air currents without recognizing the geopolitical barriers, right, or the boundaries. Global interconnectedness, that is another factor. Modern international travel and rapid aviation mean a pathogen originating in a remote village can spread to another continent in a matter of 2 to 3 hours or sometimes max to max 1 day, right, like SARS-CoV, COVID, influenza pandemics, monkeypox etc. are the examples. Now, coming to the next point is shared environmental and vector dynamics. Now, because of climate change, deforestation and global warming, there is alteration of vector habitats globally, which is redistributing diseases like dengue and malaria to previously non-endemic high latitude countries. And finally, collective health security, because health in one country directly impacts the health worldwide, necessitating the international frameworks like the International Health Regulation IHR and Global Disease Surveillance Networks, which is managed by WHO. The next explained why question was standard healthcare communication faces resistance or low adoption rates within traditional tribal communities. Now, to explain about this, you need to mention these under these headings, that cultural differences and language barriers, distrust of external system, conflict with indigenous health beliefs and top down communication flaws. These are the broad headings that you can write the answer. Now, firstly, cultural differences and language barriers. Standard health materials often use technical jargons or non-native languages, failing to align with the indigenous dialects, local worldviews and traditional folk taxonomies of the illnesses. So, it is very difficult there to invade that community or the area. Now, distrust of external system, definitely if a very learned person, a researcher comes from, suppose from Europe, a country from Europe, and then wants to do the work in Sundarbans. So, he may not get a proper history, the people will not trust him and they will not reveal their personal history to him, right. So, that is another problem, because people distrust the external system. Third one is conflict with indigenous health habits, like tribal societies often attribute illness to spiritual disharmony, ancestral wrath or supernatural forces. So, there is some conflict with the modern system, right, and they will be going to the traditional healers, they will not trust the allopathic doctors, which is another barrier for us. And finally, the top down communication flaws. Now, the traditional health communication frequently uses a one way top down approach without involving trusted community chiefs or elders, leading to cultural alienation and passive resistance. Now, coming to the next question, equitable distribution is not synonymous with equal distribution. We all know about it, it is the part of primary health care, and you know that picture of those three boys who are watching a football match from outside the stadium. So, the tall boy will not require any assistance, the middle height boy will need maybe one brick, but the small one or the short one will need 3 bricks, that is equitable distribution, right. So, equal distribution here means giving every individual or population group the exact same amount of resources, that is equal, but equity there, equitable distribution is the allocation of resources according to the need. So, equitable distribution is need based, okay, ensuring that marginalized, vulnerable or high burden population receive proportionally higher resources to achieve comparable health outcomes. Now, what is the health implication? Equal distribution perpetuates the health disparities, because disadvantaged groups start from a lower baseline. Equity or equitable distribution applies the principle of inverse care law in reverse, directing maximum healthcare resources to those who need them most to achieve the health equity. So, you know what are the main differences between equal distribution and equitable distribution. Coming to the next explained why question, that is food additives and food adulteration are not synonymous. Definitely, what is food additives? Substantially intentional, controlled and legally regulated substances that are added to the food in precise quantities to improve its texture, flavor, appearance, shelf life or nutritional value. For example, iodine added to salt is food additive, right, and fortification also later. Now, they undergo rigorous safety assessment, example for FSSAI standards, and are beneficial or safe within a specified limit. Now, food adulteration, it is the unauthorized, illegal and harmful addition of inferior or toxic substances or the extraction of vital ingredient for financial gain, reducing the quality of the food and it poses health hazards. For example, adding metanyl yellow to turmeric, urea to milk, etc. So, the core difference of Additives and adulterants are additives are added legally for benefit, whereas adulteration is illegal, deceptive and gives some harmful effect. Now, the last explain why question in paper 2 was genetic makeup is becoming an ever more important determinant of individual health. So, in explanation of this you can write under the headings of first one would be transition to precision and genomic medicine, second is pharmacogenomics, third is gene environment interaction and finally gene therapy or screening. Now, in transition to precision and genomic medicine, we can write about the advances in full genome sequencing reveal how specific genetic variation or genetic mutation dictate the baseline susceptibility to complex chronic diseases. Like we all know BRCA1 and BRCA2 in breast cancer, right, HLA markers in autoimmune conditions. Second would be pharmacogenomics. Now, individual genetic profiles determine variable drug metabolism rate like CYP450 enzyme polymerism modifies the response to drugs like warfarin or clopidogrel. So, this comes under pharmacogenomics. Third one is gene environment interaction. As environmental exposure levels normalize in modern urban life, underlying genetic susceptibilities explain why specific individuals develop the lifestyle conditions like type 2 diabetes, hypertension and atherosclerosis under identical environmental triggers. And finally, you may talk about little bit about gene therapies and screening. Emerging primary prevention strategies focus heavily on earlier genetic screening like pre-implantation, neonatal screening for PKU, thalassemia, etc. and gene editing therapies. Okay. Shifting the focus of health from reactive treatment to genetic risk mitigation, which is very important. So, the last question was very important because it is little bit different than the normal questions, that the genetic makeup is becoming an ever more important determinant of individual health, and I hope you have understood how to write the answers of these questions. We have explained paper 1 and paper 2 both, and all the best for your exam. Thank you very much.